Hi, welcome to the world of cardiology. This is Dr. Jaitly, the study of the heart we're talking about in these video vignettes. Welcome to the discussion of how do you diagnose and treat diastolic heart failure or DHF. Now, commonly it's a myth that all heart failures should have a reduced systolic function, correct? Well, it's a myth. And in fact, 30 to 40% of the heart failures tend to have normal systolic function. In other words, preserved systolic function. Now, we're talking about concentrating only in the left ventricle here. Look at it in the right panel. So here, the contractility, if it is preserved, that means it's more than 50% and above, that's considered as normal systolic function. But if the patient has individually signs of heart failure, like exertional dyspnea, lack of exercise tolerance, fatigue, jugular venous distension, tachycardia, pulmonary rales, or peripheral edema, or swelling over the ankles. Those are all signs of heart failure, but you can't tell whether it is systolic dysfunction or whether it is diastolic dysfunction. So a preserved systolic function in the presence of all these symptoms and signs classifies it as diastolic heart failure. But the key is, how do you know whether it's systolic heart failure or diastolic heart failure? You just have the symptoms and signs when the patient arrives to your office, right? So the next thing you resort to do is do a BNP level to confirm the patient has heart failure. Now, BNP is very sensitive and specific for both types of heart failures, systolic as well as diastolic. By the way, I should mention there is a combination heart failure as well, almost to the extent of 20 to 30% in the heart failure population, that you will have systolic and diastolic, both heart failures, just to confuse the matter a little more. But just to delineate and discriminate between systolic and diastolic for a second during this video talk, my concern is so that we understand how we can diagnose and differentiate between the two, and then how will we decide to treat. So the next step is automatically the chest x-ray. Now, chest x-ray remarkably shows cardiomegaly in systolic heart failure because the ventricle size is enlarged or dilated because the systolic function is reduced, and hence the left ventricle is not contracting too well. Over a period of time it starts dilating. So the end diastolic volume, like I've shown here, will be higher and higher in patients who have reduced ejection fraction or systolic heart failure. So that's one clue on the chest x-ray. Again, it's not very specific, but the fact is that in early systolic heart failures, you may not have an enlargement of the left ventricle, or sometimes may not be as closely evident. So it's still it was a very age-old test. People resorted to do a chest x-ray in those years, and these days it's not commonly done, but just so that if it's done for any other reason, say if it's a smoker or you're suspecting any lung disease, or you wanted to see if there's pleural effusion, water collection in the pleural space, or pneumonia, if you're suspecting a patient still has shortness of breath and fatigue, etc. Symptoms and signs could be very misleading because they could be non-specific over a period of time and they could be overlapping. So you end up getting a chest x-ray. For that reason, yes, a cardiomegaly will be helpful to suggest a systolic heart failure, but absence of cardiomegaly does not rule out systolic heart failure either. So next step is 2D echo or a color Doppler. And when you do a 2D echo, that'll clinch the diagnosis right there. How? Well, we know that the filling is impaired. Now, here's the filling. Now, let's move to the left panel here. When you look at the left panel, in a preserved left ventricular ejection fraction where you have only diastolic heart failure, the end diastolic volume, say to begin with, was 150 cc's. Then systolic volume goes down to 70 cc's at the end of systole. So your stroke volume is about 80 cc's. It can be all calculated on an echo. So now you have an ejection fraction of 53%. So the moment you diagnose an ejection fraction of 50% and above, and you have all these symptoms and signs, that person has diastolic heart failure. Now, to further supplement on the 2D echo findings, one can look for transmitral velocity, which is the velocity in diastole in the early filling phase and the delayed filling phase. Now, one sees that there is the early to late filling velocity ratio is normally more than 1. Now, if that becomes less than 1, or reversal of E to F ratio, that signifies that early diastolic dysfunction is starting to occur. But then, as the heart becomes more stiffer and the atrial kick comes in, where the atria is starting to be more powerful and send the blood into the filling ventricle, then there's a pseudo-normalization pattern that develops, and the E to A ratio again becomes more than 1. It's a little confusing. So now when you're applying the moderate diastolic dysfunction, it looks exactly the same. But the key is that you'll have a preserved ejection fraction in both cases. And then the third, as the diastolic dysfunction continues to progress, we have a restrictive pattern that develops. Then, of course, you'll see a very, very small volume in the end-systolic area, and systolic volume will be markedly reduced. And diastolic volume is also markedly reduced because you have a concentric hypertrophy or a restrictive pattern where the ventricle just fails to dilate and relax, or fails to relax during dilatation, during relaxation of diastole. And as a result, one has a small EDV and a small ESV. And in that case, a concentric hypertrophy or a non-compliant LV is suspected. Again, the left atrial kick is very prominent in those individuals, and so that will be seen as well on the 2D Doppler. Now, cardiac MR is done, but that's when you're suspecting other conditions like constrictive versus restrictive heart disease or constrictive pericarditis. Then cardiac MR could be a good reason to really be a test to be done, but normally you have a diagnosis already achieved at 2D echo Doppler level. Cardiac MR, of course, if it has to show systolic dysfunction versus diastolic dysfunction. I don't have a slide to that, but just so that you know, it compares to systolic ringing, because the left ventricle or the entire heart sort of rings into a systolic mode and then comes out as a diastolic mode. So it untwists and then rings again, untwists and rings again. So that's systolic ringing, W-R-I-N-G-I-N-G ringing, versus the diastolic untwisting motions are looked at together. The management, that is the key now. The management is not being well defined for diastolic dysfunction as much as being defined for the systolic dysfunction. But just so that you know, besides treating the underlying condition, one should treat with diuretics only if the volume overload is present. If there's no volume overload, use diuretics extremely cautiously, because diastolic dysfunction is dependent on intravascular volume. And if you deplete the intravascular volume rather precipitously, it can drop the stroke volume rather also very precipitously and can cause hypotension and sometimes cardiogenic shock. So you have to be very, very careful. A calcium channel blocker will help relaxation phase, so that's indicated. ACE and ARBs, ACE inhibitors and ARBs, they have shown to regress the left ventricular hypertrophy, because this ventricle is normally hypertrophied in a setting of diastolic heart failure. We see that commonly in elderly people. We also see the ischemia, and diabetes patients also have a similar problem with relaxation and stiffness. Ischemia, in fact, first shows diastolic dysfunction and then a systolic dysfunction, just so that you know. Beta blockers are wonderful because they lower the heart rate, because invariably these patients have tachycardia, as I pointed out earlier, and they have a supercontractility, or their hyperdynamicity of the left ventricle is clearly present in many of these individuals. And so diastolic heart failure will be helped with beta blockers as they lower the heart rate and their contractility as well. Okay, so that's in a nutshell the causes, the symptoms, and the way to diagnose the diastolic heart failure, and a brief outline of the management. Okay, hope you enjoyed this section. Talk to you soon again. Bye.